Okay, so I'm going to talk about treating metastatic disease and radiofrequency ablation. The overview for this talk, I'll touch a little bit on the demographics of spine tumors. I'll outline treatment goals. How do we adopt the radiofrequency ablation technology for treatment of painful compression fractures tied up with the NCCN guidelines? Show you a little bit of clinical data. We'll talk a little bit about technical procedure consideration, and I'll close with one study, just sort of tie up what I'm talking about. This slide is sort of overall data on metastatic bone disease with different percentages there. In my practice, this completely does not apply. This is not representing my practice. I'm sure different people in their practices will. I mostly do liver. I deal with GI malignancies. So what I see is colon cancer mets to the bone because I sort of establish a relationship with the oncologists in that manner. And for whatever reason, we see a ton of hepatocellular carcinoma metastatic to the bone. That completely will not apply to any of your practices just because it's so rare and in general. But that's what I see, and prostate would be probably number 3 for my practice. But you can see that we can intervene in these patients, and a lot of these patients, actually multiple myeloma ones and prostate cancer ones, they have increased incidences of bone metastasis, but they also live longer than, for example, lung cancer patients or melanoma patient metastasis, just because the nature of the disease is more slow progressing than in other cancers. And then the problem is not really infecting one vertebra. In osteoporosis, it's more likely to have 1 or 2 compression fractures. Here you have disease involving multiple vertebral bodies. And really the hard thing about this particular patient population is that, as opposed to osteoporosis, is that with osteoporosis, the compression fracture is anterior vertebral body. The way we define metastatic disease is the met has to hit the posterior elements. So we actually have to learn how to treat the posterior arch because it's pretty common. And then we need to see how to treat the lytic lesions. And that's also a challenge. That's more or less closer to the osteoporotic fractures, is that those lytic lesions break the bone and they give access to cement leak into the places you don't want to leak because they are in posterior elements. So one thing that I had to learn when I started doing metastatic lesions is with osteoporotic compression fractures, it's really just mechanical pain. You know, they hurt when they move. With the metastatic disease, they hurt when they move because they have osteoporotic compression fracture. Pathologic compression fracture. But they also hurt at rest because oftentimes the tumor will invade through the vertebral body into the periosteum and really produce those osteoclasts with neurocytokines that resorb the bone and then stimulate pain from that standpoint. So we really want to address both components. And it's really hard to address that biological component with just cement. Because if you can't have the cement fill the entire vertebral body from top to bottom, right to left, you will achieve the same results. But it's really hard to do that, as we all know. So our treatment goals are not only to really stabilize the vertebral body, but we really want to address that element of biological pain. So we want to debulk the tumor as well, and we also want to address that biological pain that comes from the periosteum. And also debulking the tumor, I like that concept because a lot of times, even in surgery, people do resections and then they follow with radiation. And I'll show you that there is data to suggest that what we do together with radiation oncologists is actually more beneficial than if they were just to radiate or if we were to do it our procedure alone. And so we want to achieve a local control as well. So what are we up against? Well, we are up against gold standard, and gold standard has really been radiation for this, and it still is. Most places do not have SBRT. I don't know, how many of you guys are dealing with SBRT? Oh, so it's good. It came to USC. I've seen I talked to a lot of community docs. Some of the radiation oncologists don't have SBRT. But EBRT has been sort of the gold standard, where it radiates the vertebral body itself, a couple levels above, couple levels below. They can't deliver high doses. It doesn't work as well, but it does show benefit for pathologic painful vertebral body mets, not necessarily pathologic compression fractures, but painful vertebral body mets. But SBRT has really come a long way. It's shown that it can do more focal tumors, it can do it faster, it can actually produce significant benefit. And they moved into the liver, which is really what I do a lot, and it hurts me. But so now they do a lot of livers, and we have to become better at this. So we are competing against a non-invasive procedure, so we need to make sure we do it very fast, very minimally invasive. We need to make sure that we can address a focal aspect of the vertebral body. And so one thing that goes against the SBRT is that there's been studies done, and in particular that Sagal study, that demonstrates that because they are so powerful in delivering so much radiation into a focal place of the vertebral body, they can destroy the adjacent bone in that vertebral body. So the compression fracture rates of that vertebral body, or even further collapse of that vertebral body, is increased with SBRT, where we can stand out and say, well, we could do SBRT-like treatment, but at the same time, we can also deposit cement to reinforce that vertebral body. And so that's radiation oncology. Surgical intervention, I don't even counsel my patients on surgical intervention at all. I believe that patient who has lung metastasis throughout the vertebral bodies and they have really 9 months to live will not benefit from carpectomy, multi-level reconstructions, and 2 months in bed. I really don't. But if they do have neurological deficits and they have compression of the thoracic cord, the nerve roots, whatnot, surgical interventions, but they probably wouldn't hit my office. They usually, in our institution at least, referring doctors are pretty good about seeing myelopathy and organ damage before and doing appropriate triaging. And then this is where we come in, where minimally invasive therapies come in, where we can address acute pain. And we can do it in such a manner, like with radiation, sometimes they have to interrupt their systemic medications, like chemotherapy. But in our situation, we can actually do it at the time or concurrently with the radiation therapy while they are on chemotherapy. One chemotherapy that I don't like doing this is Avastin, and only because if we do run into surgical complications, the surgeons don't want to come in and sort of bail you out. And that's one thing I do not like if they are on Avastin to do this procedure. So how does this play with NCCN guidelines? NCCN guidelines are sort of a good way for us to open the conversation with the referring clinicians. It's a good way for us to sort of sit back and think about what are the goals of therapy for this kind of procedure? What are we trying to accomplish? Well, the goals of therapy for NCCN guidelines is really to increase survival, and it's linked with symptom control and pain management that contribute. If you improve pain management, it contributes to broad quality of life improvement, but that overall can benefit the survival. And then we come in here with a t-RFA procedure that, as I will show you, provides clinically significant pain relief to patients suffering from pathologic compression fractures. Other goals will include management of comfort, function, and safety, and t-RFA has been shown in numerous studies to really be safe, fast, improving comfort and function of these patients. And then really nobody likes to take those painkillers. Patients are sleepy, constipated, they fall a lot. So if we can reduce the analgesic use, we can help patients from that standpoint. And there have been trials done demonstrating significant decrease in overall pain medications, especially with targeted radiofrequency ablation. Other things that people do really when people talk about management for pathologic compression fractures for metastatic cancer, it's really adjunct to systemic therapies. They'll get chemotherapy, they'll get NSAIDs, they'll get radiation therapy, and then we are as an adjunct where not only NCCN guidelines considers orthopedic consultations, but also considers local bone pain control with radiofrequency ablation, epidural injections, etc., but also considers referrals to pain specialists, which is really us in this kind of situation. And then our strategies for pain management when the patient does see our office, also coming out of NCCN guidelines, is really address patients' pain from many standpoints. I've seen patients come into my office for pathologic compression fracture only to find out they do not hurt at that level, they hurt somewhere else, and they end up getting an epidural at the place where they hurt, or regional plexus, like the other day I did a superior hypogastric neurolysis. They thought the patient pain was coming from sacral compression fractures, they were not. And then we try to address all this, not only with all these injections, but radiofrequency ablation for bone lesions. So there's a lot of evidence in literature to really support what I'm telling you right now. There's a 10-year multi-center and single study experiences demonstrating safety, palliation for these patients, significant decrease in pain, analgesic use. There are studies demonstrating decreased pain severity at 1 month, 3 months, even longer, although we are dealing with patient population that doesn't live sometimes longer than 6 months. And then always I was asking myself, why is it not adopted more despite all this literature that's out there? Well, before the introduction of this t-RFA, really, this targeted radiofrequency ablation, all of the ablation technologies were not designed for bone. They were not hard enough to get through osteoblastic lesions. They were not maneuverable enough within the vertebral body because when we get a transpedicular approach, pathologic compression fractures happen in metastatic lesions, and really posterior elements is what you need to address. You need to get somehow to the posterior elements. And so sometimes you would have to bring the patient in a CT-guided room where you have to come in at really crazy angles to hit those posterior elements, but then that equipment really didn't have the coaxial ability to deliver cement. Because I'm a big believer that if you are going to ablate, you should cement. Because there's been a study done, and I'll show you one, that demonstrated that patients that did not get cement and they did get radiofrequency ablation went on to compression fracture. And that's very similar to that SBRT data. That's exactly the same concept. You destroy the bone, but you don't feel it. So that totally makes sense as well. So here's clinical data that I'm just going to outline a couple studies, largest largest literature studies out there, but there's more. So this, for example, one that was published in 2014 looked at 128 lesions. So it was a multi-center trial at 5 academic centers. They looked at immediate, significant, durable pain relief. They reported no thermal injuries. I also have no thermal injuries in my practice, and those of you who guys do it probably haven't either, and those of you who will start doing it, you won't have any thermal injuries. And that's because pretty much every patient of mine that I do, and as it was done in this trial, is done under moderate sedation. And actually lighten up sedation a little bit before I do this. They awake, and I forcefully come up to them and say, I'm going to start doing this ablation now. If you feel any pain going down your legs, arm, or whatnot, you let me know. And there have been a couple of cases where they start feeling irritation of the nerves, and you just stop at that point so you don't have to damage the nerves. That's opposed to cryoablation, where it really numbs the nerves, and it's harder to sort of monitor even in a awake patient. And so this patient's population reported no complications with thermal injuries, and the segment augmentation was done when required. So not all of the patients got. And then I don't have the slide, but those patients that didn't get cement, but just ablation, went on to, a significant number of them went on to have compression deformities. And more than 50% of patients had decreased pain medications that they used in this trial. This is the distribution of cancers, lung, breast, sarcoma. Really, sarcoma probably be the only one that's difficult to treat with radiation, but lung and breast really respond to radiation more or less. Again, not my patient population, but I have pretty similar results. Pre-start procedure pain score 7.5, and then it was durable, and it was effective at 1 week and durable up to 6 months after treatment. Here's another study that actually is of interest because it really concentrated on looking at the posterior elements, posterior vertebral body tumors. And then there are a significant number of these patients, so a little bit more than a third, that actually went on to had a prior radiation at that site and wasn't effective for them. Again, very common tumors: breast cancer, lung cancer, prostate, renal cell, myeloma. Of all those, probably renal cell would be the only one that's more or less radio-resistant, although with the SBRT it's been overcome now. And pain decreased at 1 week at 64% of patients. Again, a significant number of patients had decreased medication use due to pain, and there were no major complications. And you can see pre-star and post-star pain score with bipolar RFA device. Here's one patient that looked at metastatic renal cell carcinoma at 4 levels. So we are talking about T11, T12, and L2 and L3. The L2 and L3 were the levels that were ablated and were treated with cement. and the rest, the upper levels, were treated with systemic radiation alone. And you can see that on 3 months follow-up post-treatment, the upper levels progressed, but the lower levels did not, which is significant. These patients don't have a long life to live, but if they do, you want to avoid that posterior element extension into the nerve roots in the cord so that they can ambulate and not become paralyzed. This is those levels went on to get treated with radiofrequency ablation and cement augmentation. And interestingly enough, the posterior extension and epidural extension was actually retracted. We've been talking about radiation therapy, and this doesn't address SBRT. This addresses EBRT. But what is our gold standard? What are we up against as a gold standard type of thing? This is looking at thousands, more than 3,000 patients treated with radiation therapy. It was a meta-analysis of 11 different individual studies, and you could see that single fraction overall response is 60%, so gold standard is not that great. And then complete pain relief was only in 1/3 of the patient, and retreated needed in 21% of the patients. So this is what we're up against, but can we improve it somehow? Well, that's what I was saying. I think it just conceptually makes sense when surgeons remove the tumor and then radiation oncologists go on to clean up the margins. This is very similar. They've done a comparison where the patient's done radiation therapy alone. You can see the numbers are pretty similar to the slide before. But then they did RFA plus radiation therapy, and you can see the overall response went up to 93%, and then complete pain relief has significantly increased. And then time to pain relief was also shorter, which is really great. So I think there is a huge benefit of doing this kind of therapy together with radiation. And then if we can combine us with SBRT plus kyphoplasty, I think we can really do some good for patients. Why not just cement? I think it's very intuitive. Why not just cement? Because I think if you can take those metastatic lesions and you can fill completely with cement, cement has exothermic reaction at the very end, so it heats up. It probably would kill the tumor just by heat, but you have to make sure it goes and spreads throughout the vertebral body and addresses every single tumor cell, which is hard to do. And if you missed it, then you have to go back with radiofrequency ablation, which will be impossible to go through cement because the vertebral body has been already cemented. So it's best to do it right off the bat to see if you can control that tumor and fill it with cement. I think you've seen this slide several times. To me, I think patients that did not respond to radiation have radio-resistant tumors. Tumors that have received radiation and maxed out on radiation, etc., they really will benefit from this procedure. Patient selection, actually, I think we talked about that for osteoporotic compression fractures, very similar. I require an MRI and CT for everybody. I hate bone scans, can't stand bone scans. I can't, it's so hard to read them, and especially when you get into thoracic levels to count if there is so much degenerative disease. So I try to get as much MRI and CT as possible. If necessary, get a bone scan, but I will always get a CT scan to see if I can correlate the levels. That's the biggest thing for me. So everybody will get an MRI and CT scan. MRI because I want to see the epidural extension. I want to see the nerve roots because I need to think about them when I ablate. I want to see the extent of soft tissue outside of the bone because I need to see if I need to treat there or not. So MRI is very valuable for me from that standpoint. Yes, you can see fractures at times on MRI, and more often you can see the clefts on T1, but really CT will show you bursts and other little fractures that go onto sides, up and down to them. And then when you deposit the cement, you kind of keep that in mind. And I would not do a kyphoplasty, vertebroplasty, or t-RFA without combo of MRI and CT. That's just how I practice. Thinking about patients who, and honestly, most patients who have metastatic disease have had a CT of the chest, abdomen, pelvis, and they will have an MRI. So it's not really an issue. And then, we look at comorbidities, we look at patients' functional status because we want to track our results. So that's important for patient selection. And again, I now start paying attention to that mechanical, biological pain differentiation. And really, when I started doing this a few years back, I was just doing it for palliation, for indicator use. because it's indicated for only pathologic compression fractures and for palliation. That's what indications are. But now I started thinking about local pain, local control of the tumor. If I can get the tumor, and I'll show you one case where it's a small lesion in the anterior vertebral body, and it's a lung cancer, I know that it will extend, then if I can ablate it and at least slow down the posterior progression, I think I'm going to do something good for that patient. And so cure, when we talk about cure, we really talk about cure of vertebral body. We're not talking about cure of a patient. But if you can get that one lesion in that vertebral body and sterilize that vertebral body, I think that could be of benefit. Again, more on MRI. I use it to detect things like this to get me out of trouble. And then the bone scan with the CT scan combination. Again, bone scan may not be great for lytic lesions. It's not great for multiple myeloma. So combination with the CT is of use. A lot of my patients have PET scan. I think it's great. It's good to get those active lesions, but really we are targeting more pathologic compression fractures. I'm not sure PET scan is something that we use on a daily basis. A lot of you guys are here, are advanced users, so this is really redundant. But as you do the procedure, during fluoroscopy, you have those safety margins. You have to outline where the canal is and keep that in mind as you progress through the radiofrequency ablation. Some people advocate breaking up the vertebral body into 4 quadrants and then identifying where the tumor is. Most of the time, the tumor will be in the posterior elements, and most of the time it will involve the entire vertebral body with pedicles. This may or may not be useful. But when you do have that one lesion that's, let's say, in the superior upper aspect of the vertebral body or in the superior lower aspect of the vertebral body, you can take those measurements or those locations. For example, in this case, where the tumor is in the left upper aspect of the vertebral body, and when you plan your ablation, some people advocate where you could target on the fluoroscopy to get that superior left aspect of the vertebral body. If you did want to sterilize this, though, if you go back here, you can see that even if you drew that cross there, the vertebral body tumor, the vertebral body tumor extends a little bit anteriorly, and it does get really to the midline. So if you want margins, I do it a little bit differently, and I'll show you how I do it. But that's one way, so you can break up the vertebral body in quadrants and do it that way. So this one is an example of sort of how I approach patients with pathologic compression fractures. There will be a separate session and more cases. This is just a close of how I plan out the procedure. This patient was a 56-year-old man with a subacute onset of upper thoracic pain, no history of trauma, pain at rest and mild increase with movement. Physical exam, there's focal pain in the upper back area, neuro exam was normal. Patient was status post liver transplant 2 months ago. Again, that's my patient population. I see a lot of HCC. And this was a new onset of back pain that led to the diagnosis of metastatic HCC. Now, metastatic HCC in a transplant patient, that's a death sentence, 2 to 4 months, clearly. So you can see in the upper thoracic levels, there is abnormal T1 weighted signal on sagittal MRI, and it is abnormal here on axial images too. You can see the tumor up in the upper aspects of the vertebral body with the anterior extension. So what is my goal of therapy? Well, my goal of therapy is really reduction of tumor volume, but mostly I want to address that posterior aspect, a reduction of tumor volume in the posterior elements, and then I would like to reinforce the vertebral body and treat the fracture itself. The upper levels, whatever reason, I'm sure that there are some advanced users here who would like to do upper levels under fluoroscopy. I personally prefer to do upper levels under CT because I can see exactly the placement of the needle. I can measure the distances, like for example here the arrow points where the sort of breach of the cortex is with the epidural space. And then I can use different ablation devices. There are 2, the smaller and the bigger one, that we could target the ablations of the vertebral body itself, and then I can pull back into the pedicle and control the time of the ablation to control the width of the ablation as well. So for example, this patient with moderate sedation was done. 2 different electrodes could be used. One is to, when you get into the central portion of the tumor, you really want a bigger ablation. You may target something on the order of 3 by 2 or 2 by 1.5. And then, as you could see on the previous slide, you can bend and target that device to the more closer to the posterior elements. And then as you pull back, you can either use the same device or switch to a smaller device and carry the ablation for a shorter period of time to get 1 by 1.75. 1 by 1.75 in the pedicle is really safe because it's 1.75 diameter. So it's really half of that in radius, and pedicles are more likely are larger than that. So you should be feeling safe to do that, and the patient is awake. So if there's any issues, they will tell you. And that's the slide that you already seen from Bob, but you could see that depending on which device you use, you can control the ablation to be smaller in width, shorter in length, and that could help you navigate within the vertebral body. And then at the end, we filled that with cement. The nice thing about this cement, really, and that's how I was converted to DFINE years ago, I started doing sacroplasties with that, is you can put the needle into the vertebral body and walk out in the control room, and it's 1.3 cc's per minute, and you can just start and stop it. And then if you're really worried, you can do frequency CT scans every 5 seconds if you wanted to, but I tried to start out at anywhere between 15 and 20 seconds, see where it goes first, and then I may become more cavalier or less cavalier depending on how the cement flows. I really like that. You can use CT fluoro. I hate CT fluoro because there's just more radiation to me. I'll take that 5 extra minutes to walk out of the room. But some people like CT fluoro. You can do that too with that device. That's pretty much it. Thank you.